Good evening, everyone. This is our 9th episode of the Anesthesia Incident Registry rounds. And I'm very grateful to the entire senior colleagues who have supported us throughout this project, our reviewers team, and of course, the entire team of APSA ambassadors who've been the backbone of this entire project. So today, we are back to our schedule of Thursday evening, and the last time we were clashing with one of the very important webinars of College of Indian Society of Anesthesiologists, ISA and WFSA, and hence we had to reschedule it to a Friday. But we are back on Thursday at 7 o'clock, and we have a very good, interesting speakers this evening. It's my pleasure to invite Dr. Praveen from Visakhapatnam. He is the secretary of the Indian Society of Anesthesiologists branch there, associate professor at the Andhra Medical College, and a keen academician. We are also joined by Dr. Sangamitra from Pune, who is again academic, I would say, backbone of this entire project and also of our Academy of Regional Anesthesia, where she is the webinar coordinator and works with the academic council. Without much delay, we've got already 35 plus participants who are logged in. So I request Dr. Praveen to kindly start his presentation. Praveen, over to you.
Sure. Sir, are the slides visible, sir?
You can go on slideshow.
Yeah. So good evening, sir. Thank you for the introduction. Good evening, everyone. I'm Dr. Praveen, Associate Professor, Andhra Medical College. And today I will be talking about a very interesting topic. When is early mobilization considered too early? So early mobilization is an integral part of enhanced recovery after surgery pathways. Sir, am I audible, sir?
Yeah, you're audible. You can be a little bit more loud.
Okay, sir. So good evening, everyone. I am Dr. Praveen, Associate Professor at Andhra Medical College. And today I will be talking about when is early mobilization considered too early. So early mobilization is an integral part of enhanced recovery after surgical pathways. But there is a very important distinction between early mobilization and aggressive mobilization. The question too often asked and which should not have been asked is, when can we make this patient walk? Rather, it should have been, is the patient physiologically ready to take up this level of activity? So one might be fit to walk on the first post-operative day, while at the same time, another patient might not be able to even sit on POD3. So it is not the clock that decides mobilization. It should be the physiology. So why should we mobilize the patient early? Now, this takes back to the history in 1819, when a surgeon by name Elfram McDowell first tried to mobilize his patient, post-ovarian surgery patient on the 5th POD. And the patient was able to travel for around 70 miles on a horseback. It was widely criticized in those days, but again, this concept revolutionized as early as 1890s. So now it is an integral part of the enhanced recovery, and the need to mobilize early is prolonged bed rest or immobilization may cause muscle loss, deconditioning of the patient, may result in loss of functional recovery, a larger incidence of pulmonary complications can occur, maybe it in the form of atelectasis or increased incidence of pneumonia and other infections, raised chances of deep vein thrombosis and thromboembolism, or again another metabolic derangements like increased insulin resistance or decreased glucagon metabolism. So ERAS pathways recommend mobilization as soon as the patient is felt clinically appropriate. But early is not a stopwatch, and the correct timing depends on the physiological stability and the surgical complexity. So the key question is not how early, but is the patient ready? So early mobilization becomes too early when the physiological cost of the activity exceeds the patient's current reserve. That is, the demand exceeds reserve, and naturally there will be an inherent risk. And this reserve, that is the physiological reserve of the patient here, is dynamic, maybe in the form of volume status or hemoglobin concentration, oxygenation status of the patient, cardiac rhythm, the cognition abilities, and the surgical stability and the immediate perioperative period. This status can change from hour to hour. So this is the case that has been taken from the APSA newsletter, up to soon and down to fast. So in this particular case, it happened to be a prolonged head and neck surgery with free flap reconstruction. The intraoperative case was more or less uneventful. There were no reported incident of hypotension throughout the perioperative period, and there was no identified intraoperative precipitant. The patient on POD1 developed acute cerebral infarction. So this particular case highlights the need for increased vigilance around the early postoperative period. Though this does not establish any relationship between mobilization and acute cerebral infarction that have occurred in the first POD. So this is the article that has been published in BJS by Abdul Aziz et al., where numerous databases like EMBAS, Medline, and PubMed have been analyzed for the importance of the early postoperative recovery. And they have concluded that early postoperative mobilization provides significant physiological and functional recovery, though there is no enough evidence supporting its impact on clinical outcome that varies according to the surgical complexity and the surgical context. So before we embark onto early mobilization, the 5 domains that have to be cleared are the cardiovascular domain, respiratory, neurological domain, the surgical, and the devices domain. As far as the cardiovascular domain is concerned, the patient should be having an optimal BP with adequate perfusion. The rhythm should be normal without new onset symptomatic arrhythmias, and the orthostatic response should be optimal. The respiratory system and any new focal deficits or seizures should be immediately investigated. As far as the surgical domain is concerned, the patient should not be having any continuous bleeding, bleeding into the drains, and there should not be any wound or flap restrictions. And unstable fractures is always a contraindication for early mobilization. Devices, too many lines or drains which are unsecured is a contraindication. The patient should be having adequate strength and balance to carry on the commands. So this is a practical traffic-like approach that has been proposed by Hodgson et al. In their study, in their consensus statement, where the patients can be divided into 3 categories based on their physiological stability. So the first group includes hemodynamically stable patients with adequate oxygenation. The patients are cooperative and awake enough to take up the task. Pain is adequately controlled, and the lines and the drains in place are secured. and the surgical restrictions are minimal and they are well understood. So these patients can be classified as green group of patients, and they can be proceeded with mobilization, starting it at low and progressing. Next group is the amber group of patients. These are potentially mobilizable group of patients, but they carry an inherent risk. There is the patients we are having a baseline poor frailty index or frailty reserve, the borderline BP or oxygenation status, recent change of the analgesic protocols with sedation. There is significant weakness or delirium, multiple devices in place which are unsecured, and a fresh surgery which is complex. So in this particular group of patients which are classified as amber, there is a need to increase the assistance or modify the mobilization plan. That is, reduce the intensity, increase assistance, and then reassess for the progress. The next group of patients are the unstable patients where we should not be rushing through mobilization through instability. These are classified as the red group of patients. These are the patients with active hemodynamic deterioration, needing an escalating respiratory support, new focal deficits or seizures, that is acute neurological deterioration, where there is uncontrolled bleeding with unstable fractures, development of significant symptomatic arrhythmias. So in this particular group of patients, the patient has to be stabilized first. The problem has to be treated before embarking on to mobilization. So these are some of the examples when early mobilization is considered too early. That is, patients with orthostatic intolerance, that is an ongoing bleeding episode, or when there is vasodilatation with weak compensatory reserve, leading to dizziness and syncope on standing. An escalating vasopressor need. Important to be noted is a patient on vasopressor support is not outrightly considered as the negative for mobilization. And there is no particular limit as which is the cutoff limit of the vasopressor where mobilization is contraindicated. But when there is an escalating need of vasopressor, it is surely considered negative for mobilization. And the oxygenation is marginal, that when there is increased work of breathing or desaturation, and when there is a need to escalate the respiratory support, it is considered a contraindication for immediate mobilization. When there is a new onset weakness or deterioration in the consciousness, or the patient is not able to obey the commands, or when there are symptoms of raised ICP or new seizure incident, then the patient has to be investigated first and stabilized before proceeding on to mobilization. Residual drug effect, this depends upon the type of anesthesia and the dose of anesthesia that has been used. If larger doses of opioids or sedatives are used, then there is a chance of residual sedation or opioid effect. And if the been properly reversed, there can be chance of residual neuromuscular blockade, which can impair balance, airway protection, and cognition abilities. Surgical and device vulnerability, when there is an ongoing bleeding or unstable fracture, as already discussed, or unsecured veins or lines, they are considered a negative for immediate mobilization. So what can go wrong if we mobilize these patients who are not completely ready? There can be episodes of falls or near falls due to orthostatic hypotension, or delirium or poor balance. Hemodynamic events like sudden hemodynamic deterioration, hypertension, development of new significant symptomatic arrhythmias, syncopal episodes. Respiratory events may be a need for escalating. Dislodgement of the catheters. The surgical consequences like bleeding, procedure-specific concerns, are the new onset neurological events like immediate seizure activity or new deficits that have been developed. These need to be investigated first. No, the neurological events which have been reported are considered to be rare, but these are serious events and have to be assessed. So this is an example, a 78-year-old after a major abdominal surgery, having a frail baseline mobility with an ongoing blood loss of 800 ml. The hemoglobin concentration is falling, BP around 90/60 in the supine is feeling dizzy when sitting. Also, there has been an opioid and a gabapentinoid use overnight. So the question is POD1 itself a reason to mobilize? And the answer is a clear no, as the calendar is not the clearance for mobilization. So in this particular, we have to address the ongoing blood loss first. The volume of the perfusion mismatch has to be corrected. So we have to rethink, reassess the analgesic protocol. The orthostatic response has to be corrected and assessed.
रैकेट लाता जल्दी आने
Once
वाला
the,
आजू बाजू मच्छर पड़े भी है
once the patient's condition is stabilized, then only progress if the response is stable. So this a study has been a retrospective study that has been taken from Takaya et al. In the European publication. So a retrospective analysis of large number of head and neck free flap surgeries were done, of which 101 patients were mobilized on POD1 and 74 patients were mobilized as a control group on POD2. So there was successful mobilization in around 98.7% on POD2, while 89.1% was successful on POD1. And in both the groups, there was no significant perioperative complication, and flap loss was also not much different. So though there is a difference of around 9% in the successful mobilization, POD1 is not inherently too early, as the study shows. So the limitation of this study, however, is that study was retrospective and it applies to only a selected surgical population. So finally, the correct question that remains is this patient physiologically and surgically ready for this level of activity today? So just like any other drug, mobilization is also a dose and it has to be prescribed it like one. So the initial thing would be a passive or active range of motion exercises and repositioning on the bed itself. Then assist the patient with head up position and assist him to sit up, sit on the edge of the bed and assess the stability and also for orthostasis. Then make the patient to stand and take stand with the support for a brief exposure. If the patient is able to tolerate, then allow him to take few steps and get him transferred to a chair. If the patient tolerates this too, then allow him for a short distance walk and then progress if he tolerates this. So progress only when the current dose is tolerated without developing new onset symptoms or if there is no physiological deterioration. So when to stop? It is the patient's response that matters more than the plan. So if the patient develops any new or if the original symptoms are deteriorating, like syncope, chest pain, or the patient develops severe dyspnea, dizziness, and if there is any physiological deterioration like a significant BP drop or new onset symptomatic arrhythmias, marked desaturation or escalatory respiratory effort, if there is lines or brain instability, or if active bleeding has developed, if there is a wound concern, or if there is a new focal deficit or seizures that have developed, that the patient is developing deteriorating consciousness, we have to stop a plan mobilization, make the patient sit or lie down, take care of the airway breathing and circulation, stabilize the patient, and then reassess. So what value do anesthesiologists add in mobilization? So mobilization is not completely a surgeon's entity. It is a multidisciplinary procedure, and anesthesiologist's role is before, during, and after mobilization is profound. So he will be helpful in risk stratification, assessment of the baseline function, frailty index, and he will be chalking out the analgesic and sedation plans, analyzing the hemodynamic and respiratory reserve to take up the level of mobilization. And during mobilization, the anesthesiologist's role would be helpful in supporting the appropriate level of support, monitoring the response of mobilization, anticipating orthostasis, protecting the unsecure lines that drains of the airways, and communicating restrictions to the team, if any. After mobilization, anesthesiologists would be able to recognize delayed complications, if any, review the pain or the sedation protocols, coordinate with the surgical, nursing, or the physiotherapist team, and document adverse events, if any. So safe mobilization is thus a multidisciplinary procedure and not simply getting the patient out of the bed. So the 6 take-home rules. Early is just a goal. It is not a deadline. And it is the physiology of the patient that matters. So clear physiology before you clear the bed. And it is the stability that matters most than a single threshold. And mobilization is a dose. So start with the lowest effective dose of activity, reassess after every step. And if any kind of symptoms appear, they have to be documented as symptoms are the data. When in doubt, pause, stabilize, and then only progress. So these are my references. And to conclude, the goal of early mobilization is not to get the patient on their feet at the earliest possible moment, but to restore the function at the earliest safe moment. Thank you.
Thank you, Praveen. That was a wonderful presentation. I think you covered a lot of aspects. When you chose this incident, I was really looking forward to this talk because it's something very apt. And just few
Actually,
days ago, we had
a practical incident happened in my PG days, sir, when I was in final year at Usmania Medical College. During one of my night duty, a stab injury came. That was a communal riot case, and all the police people were there. It was an MLC. The case was well performed. The patient came out well, and he was shifted to the surgical ICU on day one. I was in EMOT posting at that time, and in the afternoon, suddenly the sister ICU nurses came running to EMOT saying that the patient collapsed, and we went there to the surgical ICU. Our HOD, Dr. Raghuram sir, was also there. The surgeon has tried to mobilize the patient on POD1, and the patient collapsed. So next, our HOD was arguing with the surgeon, was the patient ready to take this mobilization at this earlier particular time? So since that time, that my mind was there whether this case was particularly mobilized correctly or not. So when I saw this in the APSA newsletter, that incident struck me, and I volunteered to present the case.
Thank you. Thank you. It was an excellent presentation. And I am very happy to see we have 70 plus people who have logged in, of which we have a lot of senior anesthetists from India. To just name a few, we have Dr. Vibha Nayak, who actually heads the WFSA presidential theme, which is anesthesiology along the patient pathway. We have Dr. Sanjana Mukundan from Manipal Hospitals, Bangalore. We have Dr. Naresh Paliwal sir. We have Dr. Namita Sharma, who is joined in from Gurgaon. So I would like to hear from them. And of course, Dr. Manokant is here from Fernandez Hospitals. So it will be wonderful to hear from all these senior anesthetists here as to what their take is about this mobilization and how, as anesthetists, we can put our foot down. And Dr. Vibha has already raised the hand because we have to be there along the patient pathway until the patient goes home and even after they go home. So Dr. Vibha, over to you.
Thank you. Good evening, everyone. At the outset, I must congratulate both Dr. Praveen as well as Dr. Murli for taking this topic. And as you rightly said, that our responsibility does not end with extubation. It definitely extends onto the patient, whether the patient is in the ICU or in the ward, and assisting them with mobilization, though may not traditionally come in the purview of anesthesiologists. I think as the role of anesthesiologist is evolving, I think all this is going to be as a part of our overall care for the patient. I think he has touched all the important topics. I just wanted to add that there are certain devices that can be very useful for mobilization. And we have experience with a couple of them. One is the walkers that are available, wherein the patient can actually rest the arm, and it also has a brake. It also has support to put in IV fluids and vasopressors, because he's mentioned vasopressors. So you can actually put in vasopressors on that. And the second device that we found very useful was the bedside peddler. So when you said that, we need to sit the patient outside, sometimes when the patient is on vasopressors, we get them to pedal. And we've realized that, pedaling actually helps push their blood pressure up, particularly the diastolic invitation and the thought of including this topic. I have to congratulate both of you. Thank you.
Thank you, Dr. Vibha. That was wonderful. I mean to say these two things which even I have not heard about the peddling device. So it'll be good to probably share it with the audience later. I would like to hear if any other senior anesthetists or even other ambassadors who have joined here have any thoughts or anything that can add to what Praveen has already kind of highlighted.
Hello.
Yes, sir. Naresh, sir.
Good evening. It was
Good
very
evening, sir.
excellent presentation. And
Thank you
nowadays
for
we
joining.
are. Thank you, sir. It was a myth that under spinal anesthesia early mobilization is not possible, and nowadays we are presenting about thoracic segmental spinal anesthesia, and we are always mobilizing our patients within 2-3 hours.
Yeah.
If the patient's condition is, he rightly said, if the patient has some comorbidities, if patient has some hemodynamic instability, then only we don't mobilize. Otherwise, all the patients are able to move within 2-3 hours. They go to bathroom on their own. We just don't put any catheters in sort of short to mid duration surgeries actually. And the sedation we generally prefer is which will not cause post-op respiratory depression or nausea vomiting, like dexmedetomidine and ketamine combinations. We generally avoid the heavy sedations and all. That usually leads to a very early recovery. And the
So if there are no other comments or suggestions, I think we will move to our next presentation for the evening, which is by Dr. Sangamitra from Pune. And I will request Dr. Sangamitra to kindly share her screen and introduce her topic as well.
So, good evening, everyone. Is my screen visible?
Yes, it's visible. Yeah, you can carry on.
Yes. So first and foremost, thank you, Dr. Sunil Pandya sir, Dr. Murli sir, for giving me the opportunity. I'm Dr. Sangamitra from Pune, a proud ambassador, and I'm really happy to be a part of this team and to present today. However, I am, as Murli sir has said, I'm presenting a bit different today. I have taken an article from our March newsletter, the very first one volume, in which I found a very small insight on why regular audit is needed, monitoring standards in the perioperative period, the case for ongoing clinical audit. It was written by Dr. Zainab Ahmad and Neha Padi, and I was a bit intrigued because recently, after doing my fellowship in clinical governance, I got interested and what is related to audit and all. It is always scary for me because we are more clinicians. So I went through this article, and today I want to share this article with you, which is quite interesting one. So the article begins with a core problem discussion, the gap between standard and practice. And the example they have taken here is a very simple yet very important one for us, is that is mandatory monitoring standards, which we use intraoperatively, and we trace back failures in basic systems rather than complex physiological mysteries. Without an audit, we don't know the extent of the problem nor its effect. So they have described in the beginning only that regular audit answers a deceptively simple but critical question, that are our patients actually receiving the monitoring required for safe anesthesia? They have taken the guidelines from ISA, which mentions that the presence of anesthesia machine, workstation, and monitoring equipment is an essential minimum mandatory standard in operating room. And continuing with that, they have discussed about the big five. And where do we stand with them? The big five includes our ECG, NIBP, SpO2, ETCO2, and the temperature probe. And they have discussed them with their benefits and its advantages. They have said that pulse ox is a single most advancement in anesthesia safety, and disconnect intervals give us problem, while NIBP with long phases of maintenance might drop and start behaving erratically. ECG capnography equally useful but may not be universal, and temperature monitoring, yes, often the forgotten monitor in the OT, especially in our setups where the management of temperature can be significant contributor to delayed recovery and surgical infections. And they have given us an idea as where India stands. We know that we all have experience started from government medical colleges, and then we went to do our internship, and then coming for private hospitals, teaching hospitals, and sometimes we'll end up working as a freelancer in nursing homes and all. So our experience and the way our Indian healthcare system works, it is very different. Everybody has its own way of working. The government works in a different way than private. Somebody follows NABH and somebody just follows the owner of the hospital. The language and literacy barrier, all these factors have been taken care in this article. And they have mentioned that perioperative monitoring failures have direct measurable consequences. In India, they have discussed that India is considered by world in a low or middle income countries, and the India's rural sector mirrors this reality that mortality related to anesthesia is significantly higher in our country. Examples were given, and then they noticed that why regular audit is needed, not just a one-time study. They said that audit must be an ongoing process because practice drift standards once met can erode. They have said the staff turnover, equipment failure, budget cuts, and all this leads to decline in the quality of services which we give. So regular audit will identify these deficiencies before they become embedded in culture. Accountability and culture change, knowing in India we have so many culture changes, we need to re-audit to the behavior and closing the audit cycle, which is mostly missed out by us, so that they have re-emphasized on the point that regular audit will enable you to identify not only the gaps and to implement intervention, but such kind of re-audit will confirm the improvement and the changes will be sustained. So they have said that audit will be an ongoing process because evolving standards of monitoring guidelines are coming every year. Every year the guidelines are changing. NICE guidelines started in 2002 and now we are in 2021 guidelines. The medical legal and the accreditations are going on changing. NABH has come up with the 6th edition with them and the hospitals has to follow that. So they have made a very beautiful statement that a single audit is a photograph, whereas a regular audit is a film. And believing on the equity principle that whether you are working in a charity hospital or you're a freelancer or in a corporate hospital, you have to make sure that each and every patient deserves the same physiological surveillance wherever they are posted and whatever surgery they are going on. And regular audit will make this aspiration measurable. So they wanted to comment on audit on regular basis at each and every point of India so that we can build a national evidence base so that the perioperative data, as we know, is scarce in India. So they wanted to do as a multiple repeated audits and to get the data which can be clubbed together, written, oral or original or photocopied, and this will serve as a guide for us to channelize the national evidence based data for India. So they came to the most important point which scares all of us, that how to conduct the audit, and they have use the simplest tool of mandatory monitoring standards. And they told us the key objectives that we should be compliance. You have to make sure that while doing any case, we have to use the 5 panchatatvas of giving anesthesia, the monitors, the pulse ox, NIBP, ECG, capnograph. We have to make sure that we are taking care of alarm management and responding to the alarm fatigues, documentation, the core of audit, and what you are auditing, it should be clear in your mind. It is to be, in their case, was mandatory monitoring standards in pre-op, intra, and recovery period. Then I had a thought, what does it mean by audit? Whether research, we all know, research we are all taught. So where does the difference lies? The difference lies is that research aims to generate a new knowledge. It tests a hypothesis and compares a new intervention, whereas audit evaluates current practice against established standards. It doesn't entertain experimental intervention. It examines routine care already being delivered. Most of the time, it doesn't need ethical committee approval, and confidentially and responsible data handling is mandatory, same as in research. So the simple difference is researchers ask, what is best treatment? Whereas an auditor asks, are we using the best treatment correctly? So when I was going through the article, I was thinking about what type of audit they have used, whether it is structure, process, outcome, or patient experience. My favorite always have been patient experience. Let's see what others are. So structure audit, as the name suggests, examines infrastructure, staffing, equipments, or facilities. Process audits assesses where clinical protocols and guidelines are followed. Hence, the article is based on process audit. Outcome audit measure results such as mortality rates and infection rate. And my personal favorite, patient experience audit, which evaluates satisfaction, communication, and shared decision making. So look at this step by step. This article covers the ISA and WFSA guidelines. First of the thing, they decided to describe the standard chose for reference standard to audit. Fifty consecutive elective surgical cases would be enough for their study. Then they went to the third. They went to design a simple data. They decided that the data for audit is never very complicated one. It has to be collection sheet, 1 page per patient, where it will have patient ID, type of surgery, anesthesia type, and yes and no. Now, when I talk about ID, it doesn't mean you will write the name and everything in detail or put a photo of the patient. When we talk about data collection, my dear friends, we are in India and the digital India is now rampant. So DPDP Act protects every patient of us from keeping them actually keeping them anonymous. What do I mean by that? That it should protect their confidentiality. No, none of their data should be shared anywhere. It should be anonymous. If you look at our docket app, we are taking data, we are recording cases, but we are not asking the people to write the patient name or details which might expose our patient. So if you're collecting data for any kind of study, we have to keep it anonymous. My personal choice, which I will discuss later on, is from the CAHO, which gives very good perioperative checklist to do such kind of audits, which I have shown here in the image, and contains only simple yes and no questions to look for the safety protocols. So they started collecting the data. They kept a very simple objective: single observer, a resident or consultant who fills the sheet in real time. Real time filling of the sheet is very important so that the data is accurate and time to time. This helps us to give a better retrospective review, and both are acceptable for us. Then they started analyzing the data. They simply calculated the compliance as a percentage of each parameter. So I think the baseline, we can all agree, will be 100%. That will be the ideal, that every patient should get ECG, NIBP, pulse ox monitoring under anesthesia, and that they compared with the data they got. So a basic Excel sheet was sufficient and no complex statistics were required. And then they presented the findings. They shared with their department with a brief presentation and printed summary. They highlighted the areas where high compliance was noted, and then they noted where it fell short. So did their work ended here? They got the data, they presented to the HOD, and all are happy? No. Here where the important work starts for us in audit. We have to identify the reason for gaps. Why there was a difference between ECG being used 84% instead of 100% in all the patient. They have to check whether the equipment was unavailable, whether it was a staff habit of not putting it in a spinal case. Okay, it's a spinal, doesn't need an ECG, or a documentation failure. They already forget to document it. The reason determines the fix, and a brief team discussion often surfaces the real barriers. Then you have to give a chance to make the change. So they implemented a change. They introduced one focus intervention based on findings, a laminated monitoring checklist in each OT, a prompt on the anesthesia record form, a brief staff orientation, or a formal equipment procurement list was followed by them to make this change. And then they did re-audit. The most important step to complete your audit cycle is to do re-audit, because unless you repeat your audit after 3 to 6 months, you will not be able to complete your cycle and come to know whether what interventions you have suggested in the audit has been accepted and taken place in the culture of your hospital. So, the cycle which they have mentioned here stepwise comes from a very standard protocolized cycle of 5 steps which you can find in NICE guidelines, you can find in WHO patient safety checklist, you can find in the 6th NABH accreditation, as well as the recent CAHO clinical governance which is written by our Balavenkat sir. So the steps are very simple. Remember, 5 steps, one solution, as said by Aishwarya. First is to establish the best practice standards, collect your data, provide feedback, identify and implement the change, and continue monitoring. So how does these steps help us? These steps, the first one is they have focused on mandatory monitoring standard. They decided that that will be their focus, and they have trained their staff to make sure that they understand that this monitoring is important to keep their patients safe under anesthesia. Then they started collecting the data in a very chart form, which they have said in Excel sheet, and then they calculate the percentage and compared with standards. Then they noted all the high compliance and failure area identification, and all these things they presented to their department, and they trained their staff, and they never forgot to do the audit. These are all described by CAHO, NICE, and APSA. Now, my dear friends, we have to remember one side. While we were talking, it sounded very technical, getting data, collecting, making charts and all. There is always a human side of audit. Audit has both technical and cultural aspect. If we perceive it as a policing mechanism, there will be resistance. But if we frame it as a learning opportunity, then participation from your own people will increase. It is a just culture thought, which means that we have to encourage reporting, reflection, and improvement without fear of unfair punishment. Every person in your team should be given an experience about this just culture. And yes, that's why your leadership matters, because unless you commit to the quality and transparency to your audit, it will not become an organizational identity, rather than it will remain an external obligation to complete an audit as required by the seniors. So, clinical audit in the Indian healthcare sector, we can all see NABH, CAHO, and APSA strengthening the need for clinical audit as component of healthcare excellence. They recognize that it is needed for standardization of patient care, regulatory the compliance, risk management, and patient trust. It helps us to ensure that best practices are not confined to policy documents, but translated to bedside practices. When I go for doing any clinical audit, I look for the CAHO white paper guideline, which I follow thoroughly, and my choice is mostly of patient-reported experience measures. Here I have shared the table of content. If you look, you can get for each and every department of your hospital, and you can apply it and use these charts for the data and audit of your clinical audit for your patients. So this was the one which I use for anesthesia. Simple yes and no from CAHO, and it helps me to audit. The first one I did for my first batch of DNB when I was teaching them PAC, and it really helped me to know the fallacies. They would not ask allergy, they would not ask smoking history to the female. So the cultural inhibition I could note, and then we could make the changes and could guide them that each and every patient but only if they're consistently applied and regularly verified. In a country as vast and unequal as India, audit is not only an academic exercise, it is a necessity to identify evidence practice gaps and improve our practice. And regular audit closes that gap, one OT, one checklist, and one cycle at a time. So, this way, there are references which you can all go through. They're beautifully explaining the role of Indian healthcare, world healthcare, and audit. And in the last but not the least, I will say that in God we trust, but for everyone else, we should edit. Thank you. Thank you so much, sir.
Thank you, Dr. Sangamitra. In fact, this is again a topic dear to my heart, so I thoroughly enjoyed your presentation. Thank you. And we do have a couple of people who are in the thick of things, you can call it, when it comes to audits. We have Dr. Manokant, who's been with Dr. Sunil Pandya and team, and they have a regular auditing system. And we have Dr. Pradeep Dongre here, who has been instrumental in a few of the key ISA guidelines which have come out. He's been the main architect for these ISA guidelines. And he, of course, is on the editorial board of our APSA newsletter. So I would like to hear from them what they felt about the presentation and what they would like to add. Manukant, Pradeep, anyone of you?
Wonderful presentation, Dr. Sangamitra. And I am sorry, I'm driving. I totally agree with you that audits have to be a part of, um, any clinical, department. And I still remember my postgraduate days when there was no guideline or no, NABH, nothing was there. And whatever we did it. And we only had to go back. If something went wrong, we had to go back and look at our textbooks and see whether what we did. So it was more of self-correction. Nowadays, there is a standard protocol which we can always follow. NABH is doing a lot of it. CAHO is doing a lot of good work about it. And I think, as mentioned here, many things have to penetrate even into the rural sector. That is one thing that I personally feel. Having a future goal. Thank you.
Thank you, Pradeep. Thanks. I didn't know that you were driving, otherwise I wouldn't have asked that question because
Actually,
we
I
are
was.
talking about safety. We are talking about
Yes.
safety here, and I didn't want to do something unsafe, right? So I think Dr. Vibha has got her hand up. Is it from earlier or now, Dr. Vibha?
No. Sorry. I raised again.
Yeah.
Wonderful presentation, Dr. Sangamitra. Really liked it. And I also agree with what Dr. Pradeep was saying. One point that I wanted to add to Dr. Sanghamitra's presentation is that she mentioned that re-audit helps close the audit cycle. However, in my experience, the initial re-audit, which is done, say, 3 to 6 months after an intervention for improvement, may still be forgotten, and a second delayed audit may be required, which is usually done after a year or so of the re-audit. And that is when we really realize that, is it just that because we were pushing and creating that awareness that they did it for a few days and people have come back to their normal practices, or that it has really stuck to them and it is being continued? So I just wanted to add the point of delayed audit, the importance of delayed audit. And I really agree with what probably you have said and Dr. Pradeep has mentioned, that audits need to be, amongst the younger generation, we need to inculcate this practice of doing, rather than doing futile research. I don't want to say research is really futile, but some of the topics that are assigned to the young MD students can be very something that doesn't really impact clinically, whereas audits are something that can help change our practice. And there is some way that we need to transition from, as I said, doing futile research to useful clinical audits. And probably the driving change could be not making research just compulsory, but probably making audits also a part of something that the students need to do during their training period.
Thank you, Dr. Vibha. Thank you. So coming do audits on a mandatory basis, and it needs to be on your CV if you need to apply for the next job. So as you said, making this a mandatory thing for trainees might be a very useful thing. With JCI and NABH, of course, there is some amount of audits that do happen, but how much of them actually lead to meaningful changes is another question. And Dr. Vanilla is here, and she's also somebody who is very passionate and an ambassador for audits and registries. So she's in fact commented on the chat box saying that, yes, we should be able to do this much more and much more robustly in the future. We also have Dr. Trishul. I saw his name here because he's one of our APSA core team, and he has actually been instrumental in the newsletters, and he has done multiple audits with me. And he's also here in the. We have got an excellent team
Thank you,
today,
sir.
in fact. So we have Manshad, who has actually commented. He's pitching in from the Middle East. So a lot of bright minds here I can see in the chat box, and thank you very much for joining in. And there is a plan by APSA to probably go ahead and do something like the critical which I think should reach to various policy-making boards, which is something which we need to keep in mind. Is there anything else that anybody else would like to add? Any?
Sir, can I ask one question?
Yes, please.
Yeah, I'm Dr. Alpa from Mumbai.
Yes, please.
Regarding this first presentation regarding mobilization, especially in NORA cases. So when our job is done, like our recovery criteria, shifting from recovery to step down or ward, and from there, and our role ends at what stage? So what are the things like?
So in fact, if you look at your hospital protocols and your standards, you should ideally sit with your either safety committee or whichever committee is in charge of this, right? And as a anesthetist, you should be an important stakeholder in setting standards as to what is the correct endpoint that a patient should reach before getting discharged. So you have right now a discharge point from your OT, you have a discharge point from your recovery room or your PACU, but you should also have a discharge point from the hospital. So most of the daycare units, if you look at ambulatory surgery textbooks, articles, all of them have very clearly identified what these criteria should be. But again, these are set many a times in the Western world, high income group countries. So we need to make sure that for our Indian setup, where the community support might not be that much available when patients go back to home, you might not even have a road which might have an access to an ambulance, forget anything. So we need to be very sure that our criteria should be a little bit more watertight when we send these patients home. So I would encourage you to actually sit down, read a few articles about ambulatory surgery, what are the standards which are there for discharge, and then sit down with your gastroenterologist, sit down with your hospital management and say that we want to be safe in this hospital, let's have this criteria. So that is probably the way forward.
Sir, that modified Aldred's criteria, if I write down in the discharge summary from the recovery room, from the recovery area, so is it okay for me that from my side or my role is
See, that's what I'm saying.
Like...
what Dr. Vibha is saying, and where we are going is we need to kind of become owners of this pathway, right? The patient is ours. So from the time the patient actually comes from home to the time the patient goes home, and probably even after a week or 10 days, we still have impact. So what you do in OT doesn't end by just sending them back to ward, right? It can still have an impact after a week. The patient might have cognitive dysfunction. We have Dr. Ravi Teja here, who has done wonderful research in cognitive dysfunction and is partnering with another top minds in the world. So what we do, what are we actually doing to the patient? Are we harming a nephron, neuron, myocyte? What are we doing? So we are responsible. So I think you should actually sit down and say that, yes, I've given anesthesia, I've given sedation. I want to be involved in the patient till the patient goes home safely. So I think you should actually put your foot down and take that call.
Okay, thank you, sir.
May I pitch in?
Yeah, please.
Yeah. Ideally, these protocols and have to be framed, and standards of your hospital have to be framed by all the stakeholders. Okay, and you have to be a part of it. You have to insist that these protocols, you have to be a part of such protocols wherever there is a, your involvement is there. So such things and all, you have to, sometimes you may have to put your foot down and say, I want to be involved in this, because this is the reason why, and we are working as a team, and we are all stakeholders in this. So please, I would like it if you, really consider my point too. I think it may take some time for you to get it across, but I think eventually they will.
Dr. Vibha, you had anything to say?
I completely agree with what you said and even what Dr. Pradeep added to her question. One point I wanted to say is that if you really want to even look at the medico-legal aspect, any major complication that can happen to that patient, irrespective of whether the patient is in the hospital or outside, within the first 24 hours, would be attributed to anesthesia. So whether you want to take up that additional responsibility by yourself or no, you are medico-legally bound to. That's one. Second thing I wanted to help her in identifying, she mentioned, can I use modified Aldrich score? So there are post-anesthetic discharge scoring systems that are available. You could Google that and you could make that as a reference. But like both of them said, you need to incorporate what is relevant to you, what is meaningful to the way your hospital and practices are. But that could be used as a reference to develop it. Thank you.
Thanks a lot. Thank you. So if there's nothing much happening on the chat box here, I think we can call it a day. It's been a wonderful 1 hour of good engaging discussion. And as a routine for this meeting, I encourage all of you to kind of share one incident. I think Dr. Vanilla has got her hand up. Dr. Vanilla.
Yes, hi. Thank you for the nice topic. So I was just going to say, sometimes when they do blocks and regional and daycare, they kind of have they go loose on when they actually discharge, and the surgeons tend to say that this is daycare, we need to discharge. But I think the anesthetic post-op rounds is very, very important. Even though we have discharge from recovery, still discharge from daycare should also be mandatory. I think that is something that we started auditing because we have a high turnover, and to prevent problems, because there's a lot of people visiting from outside town, and it's not like the strict daycare criteria that we have in foreign countries. They don't always go home with an attender. They sometimes go to a hotel room. We have visiting. So it becomes very much a medico-legal issue before we discharge. So I think that's something that you can include in your criteria for discharge, that a doctor must see the patient before discharge summary is made.
Yeah, rightly so. Thank you.
Thank you.
So I think we will call it a day. The other reason being I have to log into another meeting. Sorry. So it's been a wonderful evening. Thank you, Dr. Sanghamitra. Thank you, Praveen, for these wonderful talks and deliberations. And as I was mentioning earlier, as a rule, I would like to say here that kindly open the doc tab. If there's something that you come across in the last 10 days, a week, kindly put it down there as an incident. It's completely anonymous, as you know. We have now crossed 165 incidents total.
Thank you, sir.
Good night. Good night.
Thank you,
Right.
sir. Thank you.
Thank you, sir.